and welcome to Conversations with. I'm Courtney.
And I'm Keith.
And we are the clinical team here at Burtons Academy. With our combined passion for monitoring and ventilation, we're here to rewind and remind you on the foundations and principles used to form the knowledge and understanding in everyday anaesthesia. And in this week's podcast, we're talking about lung volumes and functional residual capacity and everything that's important when we are ventilating our patients. So I'm going to be asking Keith some questions about FRC because that's something that I've been learning quite a lot about. So Keith, as an overview or just as a starting point, what is the FRC in relation to lung volumes?
Okay, so I think this is one of those topics that everybody kind of thinks they know and they get taught at nurse training or vet training, whatever. And it's one of those things I think that just the concept slips people by. So FRC is the functional residual capacity. I think we can all bring to mind that picture of the sort of squiggly lines showing you a tidal volume in the center of a graph, and then we got that massive inspiratory reserve and the big expiratory reserve, and it shows us the tidal volumes, and then there's that classical breaking it down into tidal volume, inspiratory reserve, expiratory reserve, residual volume, inspiratory capacity, vital capacity, all those different capacities. And I think, as students, we all sit down and we learn those religiously and work out what is vital capacity and what is inspiratory capacity. And we work out and remember what they all are. But I think what we lose in doing that is we lose sight of what some of them really mean. So I think it's very intuitive what inspiratory reserve volume is. So you breathe in and breathe out, it's normal tidal volume. And when you finish breathing in a tidal volume, you can take a bigger breath, and that's your inspiratory reserve. When you breathe out, you can breathe out a bigger breath, and that's your expiratory reserve. But I think what gets lost is the concept of what happens or what state the lung is when we've actually finished exhaling a normal tidal volume breath. So just going to take an example. Of myself sitting here breathing tidal volume about 500 mils, say about half a litre. Okay, so I breathe in half a litre, I breathe out half a litre. The important thing, I think, is when I finish breathing out that half a litre, my lung is at rest, and how much lung volume is remaining in my chest. And I think that's something that people have no real concept of. Certainly a lot of vets and a lot of nurses I talk to, I've talked to some recently, and we've had suggestions that there may be something like 50 mils left, 100 mils, 250 mils. So I think a lot of people might be surprised to learn that when I finish breathing out, I've got a capacity in my lungs of remaining of about 3 litres. Okay, and you think, wow, 3 litres, that's a lot of reserve volume. So what does it mean? Well, the thing is, when I'm breathing normally, that tidal volume is superimposed on that 3 litres. So my half a litre is going from 3 litres to 3.5, back to 3, up to 3.5. That's my tidal volume superimposed on that functional residual capacity of 3 litres. You translate that to a dog. So you've got a 30 kilogram dog, say it's got a functional residual capacity of 1 litre. That's breathing in and out 300 mils. So it's going from 1 litre to 1.3, back to 1. So we've got that capacity there that is probably way in excess of what people have in their heads as to the volume of the lung at the end of expiration. I mean, from yourself, Courtney, is that the sort of thing that you were aware of? Is that a concept you were familiar with as you were going through, nursing training or subsequently when you were ventilating?
I definitely don't think I had it taught to me where everything was broken down. I do remember the graph being thrown in front of me and then just being like, this is the tidal volume. If you take a bigger breath, it's this. If you push out, it's, you start going through your expiratory reserve volume. But the FRC was a concept that I knew of, but I don't think I could relate it in the graph form. So I was like, oh, yes, we must preoxygenate to, fill up the FRC with 100% oxygen. But I think I've been purely just reciting that as the things we should be doing without actually fully understanding it. And then I did read a sentence recently that said, the FRC When you exhale, your lungs just don't collapse like a burst balloon. They are held open and suspended. So it's not until I started to really appreciate that the FRC is made up of you pushing out your expiratory reserve and then just the residual volume of your lungs being open that I started to understand its actual importance. So I don't think I was taught it, but now I'm understanding how important that is for ventilation.
Yeah, and I think that's the thing. It is very important to ventilation, and I think it introduces some, or begs some sort of explanation. Really, why have we got this FRC? And I only taken a couple of examples. Say you got a dog that's sat there breathing at 20 breaths per minute, shall we say? Okay, and it's got a heart rate of maybe 80 to 100 beats per minute. So we got a ratio there of breath to heart rate of say 4 to 1, 5 to 1. Okay, so what we're saying is that for every breath we can have 5 heartbeats. So if we had no functional residual capacity, we would have to match every heartbeat with a breath, so that as the heart pushed that blood around the lung, we'd have to totally coincide it with a breath being taken into the lungs full of oxygen, so we could pick up that oxygen. But if you have the bigger the FRC you have, the bigger that residual volume that you have, then obviously between breaths, each heartbeat can pick up oxygen from that FRC, take it away. Next heartbeat, no extra oxygen being added because we're between breaths, so it picks up a bit more, and it basically acts like a reserve. So the FRC is important in terms of reserve. Probably going to slide off on a little bit of a tangent here, but just to talk about FRC and its importance, let's think about something like a horse. So a horse has got a tidal volume of 6 litres, 5 to 6 litres, shall we say. But it'll have an FRC of something like 20 to 25 litres. That's massive. No, it's got an FRC that's 5 times its tidal volume. Okay, what that means is that if a horse stops breathing for a while, it's got an enormous reserve to keep oxygenating itself, its blood, its muscles, all the brain, the intestines, all the organs with plenty of oxygen. Okay, let's take an extreme of that and let's look at a rabbit. Rabbit's FRC is almost equivalent to its tidal volume. So basically, if a rabbit's tidal volume is 15 mils, its FRC is 15 mils or thereabouts. So we're on a 1-to-1 here. So that if a rabbit stops breathing, it's got very much less time relative to the number of heartbeats to maintain oxygenation to the body. So the FRC, begin to see, has a profound effect on the ability to deal with and cope with apnea, which is why rabbits are, or partly why rabbits are so bad at during anesthesia. And I think you mentioned preoxygenation. So let's just take some off-the-cuff examples. Let's say that we take a rabbit with that 15 mils tidal volume, and we have 3 kilo rabbit, and we're saying our metabolic consumption is 5 mils per kilo. So that's 15 mils over for that 3 kilogram rabbit. So basically, we got 15 mils of tidal volume, and we got a requirement of 50 mils of oxygen. Okay, now oxygen is only 21% of air, so we've only got a fifth of that 50. We've only got 3 mils of oxygen. So what you can see in a rabbit, you've got 3 mils of oxygen capacity in its functional residual capacity. So it's only going to be a few breaths. It's only going to be a few seconds. And in fact, if you do the calculation, it's about 12 seconds. Do the same calculation for a cat, it's got a minute. So in air, just breathing room air, if your rabbit's got apnea for 12 seconds, it's run out of all its oxygen. But a cat, on the other hand, is not going to run out of oxygen for, say, a whole minute. If we preoxygenate, we obviously increase that oxygen content, so almost 5 times. You go from 21% to 100%. So your rabbit now has got 1 minute of reserve, but your cat's got 5 to 6 minutes of reserve. So now that's a massive difference. And this is, again, I think, part of what goes on with rabbits as being anesthetic or difficult anesthetic cases. So you've only got a minute before all the oxygen is used up. Now we've got to intubate it, get it tied in, what have you. So that minute's very, very quickly used up because you've got 5 to 6 minutes in a cat. So begin to see the effect of what the FRC does, and how that has an influence on what the way the patient behaves and the effect of being able to store oxygen and CO2 in the lungs. So going on from that, the FRC, as we just described, is quite important. And we have to look at then things that may influence the FRC. And I don't know whether, Courtney, you've got any preconceived ideas or thoughts about common things that would change the FRC, because we're going to put our dog on the table, put our horse on the table, and how we do that is going to affect the effective FRC for our patient. And that's going to have a profound effect on its ability to store oxygen, provide it, act as an oxygen reserve. So have you maybe some ideas on what might affect FRC?
So I've always imagined that if I was thinking about a dog that was laying on the table and it was in dorsal recumbency, so laying on its back, legs up in the air, which is quite a compromising position. We've got all of this weight from the abdomen now pushing up against the diaphragm. So therefore, that's now pushing on our lungs. So even though they're able to go and take their breath, in between, like you said, that heart's still beating, there's still blood flow through the pulmonary capillaries, they're still doing gas exchange, but now they've got less of an area to do that because we've actually got all of this weight that's pushing up against the diaphragm, up against the lungs, pushing on our functional residual capacity, our FRC. So I've always imagined a very fat, obese dog, perhaps laying on its back, having a reduction in FRC, pregnancy, that's anything that's kind of pushing up on the abdomen, even something like a very compromised GDV when the abdominal contents, everything's very big, pushing up on the FRC.
Exactly. So I think that there are all these processes going on which we know are bad, but they begin to become understandable if we look at what it's doing to the FRC of that individual. Because as you said, we can ventilate them, and we can give our 30-kilo dog, a 300 mil, 350 mil tidal volume, and it will still take that tidal volume and it will breathe in and breathe out. But it's when it was awake and conscious and padding around the console floor, it went from 1 liter to 1.3. Yeah, that was how the volumes of the lung changed. It had that residual volume at 1. Now we put it on its back. As you say, its abdominal contents are pushing against the diaphragm. We've put it in a wedge to hold it in place. We've stuffed some sandbags down the side to make sure that it doesn't roll around. Okay, so now we've squeezed it from all angles, and that FRC may well have gone down from 1 liter to 0.7, 0.6 liters. We've really restricted it. It doesn't affect it. We're now ventilating, from 0.6 up to 1.1, but we're going from 1.1 back to 0.6. So we haven't changed the tidal volume that we give to a patient, but we've changed the ratio of tidal volume to FRC. And by restricting that FRC, we've changed the dynamics of the reserve, the time it takes for CO2 to accumulate and be taken away. We've changed the sort of buffer effect of the FRC. Because we were talking about oxygen just now, filling up that FRC with oxygen, and that being a reserve for the heart for every beat that comes along to take away oxygen and have that maintenance of that gradient that's going to allow blood oxygen to go from the lungs to the blood. We have to remember the other way, we're going to be dumping CO2 into this this volume. So if we've got quite a big volume, then it'll tend to buffer it. So a lot of CO2 comes back from the body, gets into the large functional residual capacity, that reserve, and sort of disappears, gets soaked up, and doesn't change the concentration very much in that lung. So it's acting as a buffer. So if we reduce that buffer, then we're going to change the way that the rapidity of response to things like CO2 and agent. So these things are all going to subtly start to have an effect on the way our anesthetic is going to progress. So they're not kind of concepts that are esoteric. These are actually going to have a profound effect on the way that the patient behaves. So we should be really careful about how we restrict our animals, how we tie them down, what we do to them. So simple things like tilting the head up slightly just above the hind legs, so we got some abdominal contents sliding back into the abdomen, so it takes that pressure off the diaphragm. Those sort of things are going to help with our FRC. So that's kind of that kind of explains how the FRC is influenced by what we do to it.
Yeah, I think that's a very interesting concept. And that's why we start to, I think, appreciate that when we hear if you have a fat or a pregnant dog, something that's obese or whatnot, that just by tilting the table, you'll improve its oxygenation. And I think as a concept, we're like, okay, yes, we must tilt the table, improve its breathing. Great. And I think we've used to think a lot, well, I myself as a nurse used to think of, oh, well, that means they don't have to have such a big work of breathing to push all that content away from their lungs. But actually, there's another aspect where if we have the table tilted, they're just not pushing on that functional residual capacity.
Exactly, yes. So all those things that we do are having an effect on that.
Yeah.
And there's something else that will have an effect on that as well. So I'm sure you're familiar with, and our listeners are probably familiar with the concept of PEEP. Okay, this is obviously to apply. PEEP applies during mechanical ventilation or mainly mechanical ventilation. But also we got the concept of CPAP, and CPAP is the continuous positive airway pressure that you can apply to a patient that's breathing spontaneously. Okay. Now we can do that on mainly ventilated animals. I understand there are some CPAP masks now available for dogs, but I have no experience of them directly. But let's just say we've got an animal on a ventilator or a system that we're able to apply CPAP to. When we apply CPAP, we see an improvement in oxygenation. That's the whole purpose of applying CPAP. But I think what is interesting is to think about what CPAP and PEEP does when you apply those. So just for our listeners, CPAP is continuous positive airway pressure, and it's the concept of applying a constant pressure of say 5, 6, 7, 8 centimeters of water pressure to the airway. So there's always that filling of the chest. So if I was having CPAP, I'd be like, I'd be having air forced into my lungs, and I'd take a breath, and it's very easy because that pressure helps the air go in. When I breathe out, it's slightly more resistant to breathing out. I only go back to a pressure of 6 or 7 or 8. So there's very little change in pressure. It tries to do what it says, keep a constant positive airway pressure, and it just does that by maintaining that pressure. So that's CPAP. PEEP is positive end expiratory pressure, and this is during mechanical ventilation. And we're doing basically the same thing. We're putting volume into the lung, and we're raising that pressure from a base level of, say, again, 8, 9, or 10 centimeters. We're taking up to 15, 16, 17, 18, 20, whatever we deem to be correct for our patient. And then it's going to drop back down, but it's going to go back down to our 10. It's not going to go to 0. So that's our positive end expiratory pressure. But what are those two mechanisms doing? Well, what they're doing is they're effectively increasing the FRC of our patient. So by increasing that PEEP, what we're doing is we're expanding the lungs slightly at a basal level. So our FRC will inevitably increase. And I think this is why concepts of CPAP and PEEP are great. They're great ideas and they explain a lot. But if you just look at the underlying process behind them, begin to understand why some animals you put a PEEP of 10 on and they're so much better. Some animals you put a PEEP of 10 on and it doesn't really respond, because unless that PEEP is able to increase the FRC, it isn't going to change anything. You can add some PEEP, in other words, pressurize that lung, but if it can't expand, then it can't improve its FRC, then the breath on top of it will be no different from the breath before without the PEEP. Does that make sense? Does that concept come across? Do you see what I'm saying? If you're going to improve things with CPAP or PEEP, you've got to expand that lung to make it better, and the exchange has got to improve because of it. And it can only do that if the FRC changes. So CPAP and PEEP, we look at them as tools to improve oxygenation, particularly in things like horses or dogs with pregnancy or obesity or anything that we want to improve oxygenation. So we look at PEEP to CPAP as those saviors or rescuers of oxygenation. But all they're doing is improving the FRC. And if they can't improve the FRC, we may see the PEEP effect, we'll see the pressure change, but we won't see an improvement in the patient. And I think, again, this is another way that understanding lung volumes, particularly that functional residual capacity, helps us to understand why PEEP is effective, how it's effective, but also why it doesn't work sometimes. So is that something you are familiar with yourself? Is that something that's a bit explained or?
Yeah, it hasn't. Well, it's been explained now, but definitely not all I was learning. But it stems so many more questions for me as well, because I think about in practice when I was applying PEEP, I was not really thinking about the FRC because I kind of parked that as a thought in my mind, and I was purely using FRC to prevent like lung collapse or atelectasis, but actually. And by doing that, I was preventing, hopefully, sort of VQ mismatches, so ventilation perfusion mismatches. And that's exactly still, I've always kind of parked that thought by being, okay, let's apply PEEP, let's keep the alveoli open, let's stop them from collapsing, therefore we won't get a VQ, ventilation perfusion mismatch, and therefore our patient will oxygenate correctly. But actually the much more simpler way of explaining it is just in the exact way that you have as well. We're still getting to the same point, just with different thought processes, but I just was never thinking about using PEEP or CPAP to improve FRC, but actually we're just keeping those lungs, the alveoli, nice and open.
Yeah, I think it's a concept, isn't it? What we're really saying is that, and what you were saying absolutely right. You apply PEEP to improve airway opening, to maintain that airway as being open, prevent collapse, and what have you. But the way it does it, or the consequence of doing so, is to increase the FRC. And if you can't increase it, then you can't make those alveoli bigger. You can't change that overall volume, and so the FRC doesn't change, in which case the benefit of CPAP or PEEP is not seen. So we're doing the same thing. What I'm trying to get at here with going back to that graph that we always talk, what does it all mean? And I think the FRC is something that gets lost, gets forgotten about, but it's tremendously important.
It's the thought is still there, the concept is still there. I just think I had all of these like scattered puzzle pieces, and I just hadn't realized that actually they all fit together and they all relate back to the importance of FRC.
Yeah, and it's a basic concept, which I think is, if you can grasp this, then you begin to understand a lot about respiratory mechanics and what ventilating does. And obviously, we're going to have in the future podcasts about ventilation and how you ventilate. But whenever we're doing that, we're going to be looking at how we're manipulating a tidal volume on top of an FRC. And if we're going to want to improve things by CPAP or PEEP, we're going to be adjusting the FRC to improve things. And there's no doubt that everything you do to improve FRC in a patient anesthetized is going to help you. So lung VQ mismatches, perfusion versus ventilation mismatch is going to be improved by PEEP or likely to be improved by PEEP. So, and it does that by changing the FRC. I mean, this may be an opportunity to just briefly talk about ventilation perfusion mismatch. I think this is probably something which again confuses people. So you got ventilation perfusion. What should it be? And ideally, it should be matched so that the ventilation matches the perfusion. And if they don't match, then you're not getting maximal exchange of oxygen or CO2 between the vessels and the alveoli. So I think within that, there are two basic concepts. So we look at dead space and we look at shunting. Yeah. And I'm sure that when you went through your training and when you're ventilating an animal now, those are the concepts that you have to consider, whether you've got a dead space or whether you've got a shunt. And just to explain to the listeners, basically what a shunt is and what dead space is. So if we have, as we talked about before, ventilation and things like dead space, if we've got alveoli expanding and collapsing, but they've got no perfusion going to them, there's no blood flow going to them at all, they are effectively dead space. Okay, so we've got good aeration, so our V over our Q, our V is very good, but our Q is poor. So we've got a high VQ ratio, we've got a high ventilation ratio, but we've got very, very poor perfusion. That's no good. We've got the other concept where we've got lots of perfusion going to an alveolar area, but those alveoli are basically collapsed and are not participating in any oxygen exchange. We've got a shunt. So basically, we've got very, very poor ventilation. So V, as our V over Q is small, and our perfusion Q is great. Our perfusion is absolutely fine, but we got a shunt. So the effect of that is no pickup of oxygen. We're just going to then mix our deoxygenated blood with our mix it with our oxygenated blood from the rest of the lung, which isn't shunted, and we're going to get that what we call that venous admixture. So we're not going to end up with a nicely oxygenated blood. We're going to have a less oxygenated blood because of that mixing at the end. So those are the concepts of shunt and dead space and what VQ mismatches are about. But particularly the perfusion side of things, that's going to come down to your FRC. The more alveoli you can provide, the bigger, or improve the ventilation for any given perfusion, that's going to improve things. So increasing the FRC has that effect, or is doing that through that sort of effect as well.
Mm-hmm. And we could be trying too hard and create a VQ mismatch, if my thought process is correct. So when we talk about VQ being hopefully all of our alveoli are perfused, that's really nice. That's perfect. And then we have alveoli that are ventilated and not perfused. And then we have alveoli that are not ventilated, but they're being perfused. So the second one being the alveoli that are being ventilated but not perfused. That could be if we put a really big pressure into the alveoli, isn't it? And we fill it up, and we compress the capillaries around the alveoli. Then they're being squished by how big the alveoli actually is, and therefore we could get a VQ mismatch. Do I have the correct understanding?
I think that's totally acceptable, because you're creating great ventilation, but we have to bear in mind things like the effects of positive pressure ventilation, which I know we're straying slightly from FRC, but if you think about pulmonary pressure, arterial pressure in the pulmonary artery, I think, don't quote me too much on this, but I think it's about 35 millimeters of mercury. That's that order of things. So if you're applying positive pressure ventilation and you're putting that pressure into the chest, that's going to oppose that pulmonary flow. So if you're putting in, say you're putting in, we normally work in centimeters of water, but if we're putting in, say, 10, 15 millimeters of mercury pressure, which is, do the calculation, I think it's about 0.8, isn't it? So 10 millimeters of mercury is like 14 or so centimeters of water, something like that. So we're putting in, say, 10 millimeters of mercury pressure. That means that the resultant perfusion pressure in our pulmonary artery is now down from 35 down to 25. So we're having an effect with IPPV on perfusion. And therefore, if perfusion was marginal into an area before, when we start applying that pressure during the period of inspiration, we're going to suppress that, and our nicely perfused and ventilated alveoli clump is actually going to be well ventilated but poorly perfused. We're going to introduce dead space by the mere act of our IPPV. So I think if that's what I think you were saying, then that's exactly the process that's going to happen. Yeah.
Yeah. Well, that's another whole podcast in itself, then, isn't it?
Yeah, absolutely. Yes. Yeah. But I think, the idea of this podcast was to introduce the concept of functional residual capacity, what it does, how we use it, and how it fits into all the other things that we tend to take for granted, like the CPAP and PEEP and the preoxygenation. And they're all relying on this reserve that the body has. And the reason it has that reserve is because, as I said, you've got to have enough reserve so that the heart can beat and pick up oxygen every time, even though the lungs are delivering oxygen at a much slower rate than the heart is picking it up. So I think I've probably covered the basic concepts that I wanted to cover here. Unless you've got any more questions, I'm happy to answer any more questions.
I was thinking I might just try and summarize it in my head. So we've got our patient's FRC. We can pre-oxygenate them prior to anesthesia so that if we do have trouble securing the airway, because maybe they're brachycephalic, maybe it's a rabbit and everyone's a bit, we only intubate a rabbit once a month and we need a bit of time before hypoxia develops. Okay, so we've pre-oxygenated. FRC is full of this really nice, richly concentrated oxygen. Therefore, if we can't gain access to the airway and secure it, we've still got a nice, rich oxygen environment in our FRC. So between breaths that our patient isn't taking anymore, we still have that safety. We've got that buffer. And then once we have them anaesthetized, we can apply PEEP or CPAP to our ventilator or to our breathing system. And we can also assist our patient by tilting them a bit, getting the pressure off their thorax if they've got big, large abdominal contents. And what about those? I've seen some PEEP valves that you can put on your breathing system so that you don't have to have a ventilator. And I think they introduce a pressure between kind of 1 to 5 centimeters of water.
Mm-hmm.
If you have a practice that doesn't have a ventilator, would you recommend one of these PEEP valves?
I think the problem with that is because you're applying PEEP to what is effectively a spontaneously breathing animal, it's going to be very difficult. The only way that's going to work is if you're manually ventilating, taking and assuming the role of a ventilator, then PEEP starts to make sense. Otherwise, you'll never sustain the PEEP with an animal that's spontaneously breathing. So it has to be something that's mechanically ventilated for PEEP to make sense. Otherwise, you want CPAP, and unfortunately, a PEEP valve won't give you CPAP. That's a slightly different concept. So yes, they're great, but you've got to have some form of ventilation for PEEP to be effective.
Okay, no, that's good. This is all my brain thinking out loud.
Sure.
So I think now I really do, in the last, while I've been learning so much about ventilation, something that I just conceptually glazed over being, FRC, just preoxygenate them and get their big bellies off their thorax. There actually is a very real reason why we should be caring about the FRC. So all these explanations help.
Okay, good. Now, I understand, obviously, we do a number of these podcasts and we've focused on some very specific things at the moment, like FRC, and we talked about some of those specific things of capnography before. Just want to kind of reassure, any listeners that we're not going to be quite so esoteric or fringe all the time. Just trying to build some baselines so that when we start talking about ventilation, these concepts start to make sense rather than trying to introduce them at the time of doing the ventilation lectures. So we're going to talk another one. We're probably going to talk about some dead space. Then when we've done the dead space one, we might just do a little bit on breathing circuits. And then once we've got that background information, we'll be starting to introduce some more about ventilation, because it starts to bring in all of those things about dead space, breathing circuits, and how they all tie together. So don't be discouraged if these feel a little bit, conceptual at the moment, but they're grounding for what we're going to want to do in the future. So great. Thank you very much for listening. And Courtney and I look forward to producing and introducing you to more of these concepts and things we need to do for ventilation in the future.
It was very interesting. Thank you, Keith. I will continue to ask questions, I'm sure, in the next lot of podcasts.
Brilliant. Thank you, Courtney.
Thank you.
All right. Bye now.
Bye-bye. Thanks for listening to this week's podcast. Don't forget to follow our podcast to stay up to date with the latest episode, and feel free to share with your team. If you have any questions or feedback for us, or simply want to know more about what you've just heard, please send us an email to clinicalsupport@burtons.uk.com. Catch you next time.